medico-legal symposium. I think it's of immense value to all because these are some common issues that we've taken up in this symposium, which are of practical importance, and if you've heard them once, you'll be able to avoid the pitfalls and the traps which come our way sometimes medico-legally. Ignorance is no defense in our favor, so we need to know some few things about the law. Is Dr. Neha Deshpande there? I think I'll start right now. Patient who died in the operation theatre, and this actually happened to me. So I had a patient who died, and I think I'll share some of the pearls that I learned because this happened for the first time. May this never happen with you. So this presentation is based on an actual incident. Patient had multiple medical problems including thyroid, diabetes, hypertension, heart disease, severe obesity, collagen disorder. Patient was flown in from Indore with bilateral corneal perforations. So it was a bilateral recent onset corneal perforations. The eye surgeon from Indore rang me up and said, I don't want to touch this patient, you please do this. So the relatives, when they came, were explained the necessity of general anesthesia because I couldn't operate this patient twice. Huge obesity, very difficult to fit on the OT table. And I discussed with the anesthetist. We spent about 1.5 hours prior to the procedure discussing the risk factors with the patient's relatives. There were at least 4 or 5 relatives who had accompanied the patient. So we discussed for about 1.5 hours, myself, my anesthetist, and the relatives of the patient, that we, in spite of all risks, we still have to give general anesthesia, and we have to do bilateral amniotic membrane grafts to try and save the eyes of this patient, and that the patient will require subsequent surgeries later if we can prevent these 2 eyes from going into phthisis. They were specifically briefed about the possibility of death on the table. The anesthetist told them that it is a very high-risk anesthesia and he may not survive the surgery. The inevitable happened. The patient had successful surgery. Luckily for me, the patient came out of anesthesia, was wheeled out of the OT on a trolley, and he said hello to the relatives. So all the relatives crowded around. He gave a very weak hello to all of them. He waved his hands. Then he had a sudden cardiac arrest while they were taking the patient from the operation theatre to the ward. He had a sudden cardiac arrest before he could be shifted to the room. Of course, we wheeled him back into the operation theatre. Anesthetist was there at the same time. All attempts to resuscitate completely failed. I am in private practice. I have a general hospital just across the road. So we called the ambulance from across the road to shift the patient to the ICU across in the opposite building. But the cardiologist who came with the ambulance declared him dead and said there's no point in shifting him to the hospital. He's already dead. He's passed away. So what next? Relatives were initially quite understanding. They said, give us the body, we'll take the body back to Indore by train because we had spent a lot of time speaking to them. I refused. I called in the police after making sure that my operation theatre notes and the anesthetist notes were complete in every way. So then we called the police. The police took their own sweet time in coming. The police station is about 5 minutes away from my hospital. They took almost 1.5 hours, 1 hour 15 minutes to come. Then asked me why we bothered to call them. They said, just get a friendly neighborhood family physician to certify that this patient died and give a death certificate, and they can take the body to Indore. Why are you troubling us? So police typically work at a snail's pace because they want to make some money in this process. So police requested me to get a friendly family physician to certify the cause of death as heart attack. and just mention that nothing happened, patient came into the hospital, he had a heart attack and died. Give the body to the relatives. Relatives also telling me, give the body to us. We understand that this could have happened. I refused, and I urge you also to refuse, because you can get into legal trouble later. So then the cops requested for 5 witnesses. In Mumbai, that's called a Panchnama, where punch is 5. So you're supposed to get 5 witnesses to be present while they talk to the relatives. The cops explained the further procedure to the relatives. First, they will do the Panchnama, they will make their own notes. Then they would send the body to the state government hospital, which is called the JJ hospital, where a post-mortem would be conducted, authorized by the coroner. Then the coroner would issue the death certificate. This would have to be taken to another government office, which would then issue a permission certificate for the body to be taken out of the state. And the police made it sound as if this is almost impossible to achieve, and it will take perhaps several hours and maybe a day or more to achieve all this. The cops took their time, but since I had a clear conscience and the relatives so far were cooperative, the cops were getting quite frustrated. So they took 2 hours in my hospital to record 2 pages of statements. There was really nothing much to record. Then they called the government hearse to take the body to the JJ hospital morgue. Now the relatives were getting tired. They'd been up at it from morning, and it was now evening by the time the body left my hospital. Sensing this, when they reached the hospital, the morgue peons told them that there were other bodies in the queue, and things could get delayed by hours unless they gave him speed money. So relatives are now tired. It's been about 8, 12, 10 hours. The class 4 employees in the morgue are pressurizing them to give speed money. I had sent my hospital manager with the patient's relatives. In spite of my hospital manager instructing them, they readily agreed and gave the peon all the money that they had. The post-mortem was then finished in less than an hour, and a certificate was issued. The morgue attendants themselves accompanied the body and relatives to the railway station, completed the paperwork required, actually delayed the train by 10 minutes. If I was the governor of Maharashtra, I could not delay a train by 1 minute. But these class 4 employees managed to delay the train by 10 minutes, put the body in the luggage compartment. Relatives, they got them second-class compartment tickets for an 18-hour trip home. What are the lessons to be learned? Take the relatives into total confidence. If patient is bad risk, spend more time, huge amount of chair time, tell them about it before surgery. If death occurs, stay cool, complete your paperwork. That is the most important thing. All your paperwork, anesthesia notes, everything should be complete. When death occurs, don't leave your hospital under any circumstances. I'll give you a story of another eye surgeon who had a death in his hospital. He got scared, he left the hospital and went home, leaving the resident doctors to manage the relatives. Relatives who were cooperative, got totally uncooperative. Where is the operating surgeon? He's run away. So there must be something fishy, and they created hell for that doctor. And the cops also created hell, saying we want to record the doctor's statement. We don't want to talk to the junior doctors. So stay cool. Don't leave your hospital under any circumstances. Continue to talk to the relatives all the time. Understand the law, call in the cops, insist on this. Insist on calling the cops even if the relatives don't agree, and getting a post-mortem done. Because there are 5 relatives here, there are 25 relatives at home. Those 5 here are cooperative, those 25 outside may not be. Read page 13 and 14 of the AIOC series on legal aspects of ophthalmology, compiled by our own AIOS member, Dr. A. Deshpande, who is a lawyer as well. He's written it very well about what needs to be done. So this AIOS series is available on the web also, and of course physical copies. Understand that you cannot be arrested. Nowhere in the country can you be arrested. It is a cognizable offense under section 304A according to Supreme Court ruling, but there is no arrest of the doctor. A death at our hands, either with consent or without consent, if the surgery or treatment is done in good faith, earns us exemption from arrest under sections 88 and 92 of the Indian Penal Code. Number 3, don't try to bribe the cops. Don't submit to blackmail by relatives or pay them money to hush up the matter. Don't talk about money, because then it feels as if you have done something criminal. There is nothing for you to hide. These things can happen. At most, you may not charge your surgical or nursing home charges, or if you've already collected the charges, you may refund those charges because the patient has died. That is up to you as a goodwill gesture, making it clear that this is not an admission of guilt. This is important. In conclusion, don't wash your hands of the situation. Stay there, stay with the relatives, stay with the cops, stay in control. You should be the person in control. Don't allow the police or the relatives to get into control. And you will never need to spend a minute like this if you don't panic. May you never face such a situation. Thank you so much for your attention. I request Dr. Nirmal to talk about a burning topic, way out to cashless capping in ophthalmic practice.
Thank you. Thank you, sir. And after that wonderful talk on one crucial issue of medico-legal importance, this is another burning problem among the practitioners. So cashless everywhere. So what are the challenges and how we can go forward? Is the audio connected?
Go. Please adjust the audio, please.
Can you connect the audio? Audio?
Thank you.
Right. How many of you are doing cashless here?
Why are there laws?
Okay.
What are laws for? Anyone?
Social order?
Just watch this video carefully. It runs for a
To
minute
protect
or so.
the person's personal rights.
So that you can rely on the government?
Justice? Thank you. Tell me, was I unfair to your classmate just now? Indeed I was. So, why didn't any of you protest? Why didn't any of you try and stop me? Why didn't you want to prevent this injustice? You see, what you have just learnt, you wouldn't have understood in 1,000 hours of lectures unless you lived it. You didn't say anything because you weren't affected yourself. And this attitude speaks against you and against life. You think it doesn't concern you, so it's none of your business. Well, I'm here to say, if you don't help bring about justice, then one day you too may experience injustice, and there will be nobody there to stand before you. Truth and justice lives through us all, and we must fight for it. Because in life and work, I mean, we often live next to each other, but not with each other. We console ourselves that the problems of others are nothing to do with us, none of our business. And we go home glad at night that we're spared, but it's about standing up for each other. Every day an injustice happens in business, sport, or on the tram. Relying on someone else to take care of it is not good enough. It is our duty to be there for others, to speak up for others when they cannot. I am here to teach you the power of your voice. I want you to learn to empower you to stand up for what is right, even
So basically this issue about this injustice being done in the name of cashless, right? So when the issue came up, many of our friends remained silent. So it started affecting the majority of them. And over a period of time, now it has come to this situation where it is going to affect everybody, irrespective of whether you do cashless or not. So the same situation that were faced by the girl who was sent out of the class without any question. So this is the basic of issue. When majority of us remained silent, it was deafening silent when it was imposed only on the providers, particularly private providers. The NGOs felt that they were too big. The medical colleges felt that they are not part of this community which they are serving. The corporates thought they were powerful, they can lobby and get things done. But now, after this cashless everywhere, everyone started pinching, everyone started scared. And now there is deafening silence because nobody knows how to talk. So this is basically the present status of health insurance. And there are so many stakeholders, and instead of we being the center of the health insurance industry, or patient being the center, we are now relegated to the last status. And there are so many other stakeholders taking the lead. So this is a complex situation. So instead of doctors and patient in direct coordination of care, now it has become indirect coordination of care. There is no coordination. It's only indirect way of treating the patient. Instead of we giving care directly to the patient, it is the insurance that is going to buy the care on behalf of the patient. So you have directly from doctors, we are now gone to the situation where we are care providers, and care providers to the people who the insurance or third party suggests. So there is complexity in this situation, and always complexity leads to confusion. Why there is sudden influx of this power politics in healthcare? Because of the huge market. If you see in 2023, the health market was 0.82 trillion, and in 28, another 4 years, it's going to be 1.36 trillion. So the market is going to be enlarged, and now that there is so much money into the system, everybody wants a big piece of the cake. So health insurance traffic is increasing day by day. That is probably started with COVID, and now it has reached an enormous situation. And this is the numbers in terms of the percentage. From 10%, it is going to be 35% in 2022-3. So I'm not going to discuss about whether insurance is a boon or bane. But the problem with insurance is increasing. Almost 99% of providers have faced problem because of insurance companies and TPAs, and 99% had to answer repeated queries and documents. So this is the time we are supposed to give it to our patients, but we end up answering insurance queries. So what health insurance companies have contributed to the healthcare? So this is a column from a US paper. The health insurance companies are useless, get rid of them. They've been successful at two things. One is making money and getting the public to believe they were essential. So this is what happened post-COVID, and the complexity increase. The moment complexity increase, the healthcare cost increase. The administrative cost from 5%, it has rose to 18%, which means that we are spending 1/20th of our money to get the insurance money. That's actually our money that is supposed to come to the healthcare providers, and now this insurance industry is going at our cost. So what we call them is, what we call others who grow at others' cost? We call them parasites, or in surgeon's language as tumors. So these tumors have to be excised once for all because they doesn't add to the safety or value to the healthcare system. So insurance is not addressing the fundamental problems of healthcare. Neither the cost, choice for the patients, access have not been improved, and the quality. This is our worry. The quality has not increased, but the cost is going up and the providers are not getting their due. So everyone is affected, the uninsured, the underinsured and insecurely insured. So it's an unhealthy sign because in Kerala and in southern part of Tamil Nadu or southern India, 200 smaller and medium hospitals closed in Andhra. Smaller hospitals keep vanishing in Kerala. We have the data of Nursing Home Board of Kerala as well as Tamil Nadu. There are many places hospitals are for sale or lease, and there are quite a number of hospitals, particularly among the eye care centers, lot of acquisition by corporates and chains. This basically it's an unhealthy sign not only for entrepreneurship but also for corporate India because the ease of business, doing business is affected. So what is the background of current situation? Basically, the universal health coverage, which is a political issue and government schemes, has now been taken over by the private insurance companies with the help of technology and in the name of digital health, and all these being done by non-health players. So this is where problem started. This is the background of current situation. From PSU companies to private insurance companies, the moment private players came in large numbers and invested that money, they wanted a lion's share of the healthcare market, and this is where the problem started and cashless everywhere came. So this is a nice table to see who's exactly funding this issue. If you see that it is funded by the government, but it's not the government money or the political money, it is funded by the taxpayer money. So which means the money that is supposed to go to the government hospital for infrastructure development is being routed through the insurance companies, and that is 30% added cost. So our money is being given to the insurance companies at a higher cost of 30% to fund the government hospitals in turn. So it's actually our money getting wasted, and this is what the table detects. I will not go into the details, but what happened in the last few years is because of this, the digital health incentive system, which is supposed to earn incentive up to 4 crore. So this is for the providers who are supposed to go into the digital health system. And blockchain technology, all of you know, technology is being integrated. Now they want all the healthcare providers to take up this and come into their healthcare exchange system, which means like the government buying power from the power exchanges, the government and companies will buy health from the providers like health exchange system. So this blockchain technology is being used for that. So what happened is replicate this Ayushman Bharat to increase the penetration across pan-India. Reach the missing middle. The middle class is basically lower middle class and upper middle class who are paying from their pocket to the private providers, and here they are planning to get this missing upper and lower middle class who are essentially paying for the services to get the insurance, and they will pay now. So with power and policy help and with the help of technology, this cashless is being promoted by the General Insurance Council. So why the private health providers have to be worried? Because 1/3 of all hospital is owned by private sector, particularly single doctor or a family run private sector, and 40% of the hospital bed is run by this sector. And in healthcare, it's very difficult to establish beds overnight. So the policy people, for the governing people, face two key challenges: very high capital investment and operating expenses. So when hospitals are already there and it's available at a cheaper cost, they want to take over these 72% of private healthcare enterprises. That is where all this policy are being designed by the corporates by the governing people to take care of this share of 72%. So basically, it is a policy issue which is being thrusted on the private players to take over their enterprises at a cheaper cost. And this is the health exchange mechanism. So now this is being pushed to all the healthcare providers to become part of this health exchange, and this is being promoted currently. So what happens? The insurers focuses on 6 critical success factors. So they want to have low claim ratio. That is the reason why in the last 1 year or so, the claim ratio is very, very less. Their large willingness to pay, so they are not unwilling to pay to the providers. That is the reason they want to have capping on everything, and they want to make their profitability, large profitability, so that they can sustain in a better way, and they want to have higher renewal and customer retention ratio. That is why all this portability, everything has come. So this business model is essentially from business to customer model. Now it is business to business environment. So it's very, very difficult for private players to sustain in this. So GIC plan on cashless, is it right? So this is a question asked by many providers. So legally, cashless is, so any state health scheme, whether Ayushman Bharat or the state schemes, are not charity. It is a right under healthcare. So it is a right of the patient as well as the public. And government or any insurance company cannot reject reimbursement claim. So this has been clearly said by Madras High Court in a judgment given in 2019. So this cashless 100% is legally incorrect. We can question that. So why do we should go against this? One is the financial strain. If you accept cashless, it's going to strain the hospital financial stability and impact our cash flow, and also we have to be dependent on insurance companies to maintain this cash flow. So this will again, in the long run, open floodgates to corruption. They might demand money to clear our own money. The second, so for this, you have to understand these 4 costs. Our healthcare cost is based on these 4 C's. So cost have to be monitored. There should be sufficient cash to maintain our payment obligation, that includes salary. There must be capital to buy equipment. If you go to the trade, there is so much money flowing as a capex. And for any business to sustain, we need to control both incoming and outflowing resources. If we understand this, we will not sign this cashless business. And we also need to manage the 5th C, that is the contract management. If you see the contract, it is totally one-sided. It is not at all in favor of the providers. So you have to take this into consideration. The second part is administrative hassles. Across the table, we were getting the money from the patient. But now what happened is, there is administrative cost. We need to employ 2 or 3 insurance administrative person to get our own money. Right? It's the money that we are supposed to get to serve our patients. So in the process, there is a cost component to space requirement, equipment costs, documentation and courier costs, and too many portals. So we have to train our employees for that, and also the security and confidentiality issue. So recently the AIIMS entire website, entire EMR system of AIIMS were hacked. With so much protection, they can't do anything, and they were taken for ransomware. So small hospitals cannot do this, so it is a serious issue. So 4th one is the standard and quality compromise. If they keep on containing the cost, so hospitals has to curtail their quality services. So this will again affect the quality of trained doctors and staff, and this is where all this analysis really helps. The 4th one is it limits complex procedures and innovation. So in the garb of packages, we are strictly made to adhere to lower cost and simple lenses, but our patients want the better quality lenses and the better technology. So it limits innovative medical technology and limit our ability. The 5th one is it affects the patient experience. Cashless system has contributed to longer waiting times, reduced personal attention, and affect overall patient experience. For these 5 reasons, and it also deny the right to care at the right time, like golden hour concept. concept. Most of our surgeries are daycare, so we have to provide service within that 2 or 3 hours. So golden hour concept has to be brought here, like acute care and trauma. So how can we solve the issues? So let me know if I'm exceeding time. 5 minutes more. Okay, so how can we work together as a group of people, as association, as providers? So risk can be managed in 4 ways. The risk transfer. So we can transfer this to aggregators, but again aggregators are going to pinch us. Risk avoidance. This is the best method, like Bombay doctors did it a few years back, that avoid cashless altogether. Maybe Dr. Muscati can give his experience. And so that is the best one, risk avoidance. Risk acceptance. NGOs, government, so if there is additional funding, you can always take the risk and do it. But again, it needs a lot of costing as well as funding from the charitable agencies or government or NGOs. So private players cannot look into this issue. So we have to better avoid the risk. And understand costing of your services. Never copy costing from the point of your colleague or neighborhood practitioners. You do your costing procedure and accordingly charge the patients. So think of hospital expenses like a magic show. So transparent costing is very, very important to know how much you are spending for your surgery or procedure or providing consultation. So second, negotiation strategies with insurers. We are all taught medicine, we are all taught to do surgeries. Unfortunately, negotiation strategies is very, very difficult, particularly with insurance companies. So we have to develop a good negotiation skill. So we have to be rigid to stick to our rates. So for that, we have to understand our costing and then only go to them for discussion. And billing and claim processing. We need to have a proper transparent mechanism for billing as well as following the billing system and tracking the claims. And we also need to diversify non-insurance revenue streams. So there are so many ways of going into this. I will not go into the details. And ask patient to rate. They ask patient to rate the hospitals. Now it is our turn to rate the insurance companies and TPS. So insurance companies are scared about this because their business is based on this, right? So we have to ask our patient to rate the insurance company services, including the TPAs. If we start doing that in a large scale across India, they will come to the negotiation table. So tackling third-party insurance, you need to have a system in place and monitor them. And what next? We have to be united. Don't look at our neighbor as competitor. So let there be uniformity among us. So it's very, very important we decide the cost and tell them this is the lowest possible rate. Beyond this, never negotiate. Work for sustainable healthcare. It's important we stick to this and look forward to working together as association to help our members and also work with all the providers as collaborators. So these are all very important issues. Apart from the empanelment issues, we also need to take care of this. So many systems, licenses, Rohini, and entry-level system. So all these leads to the complexity. So as a association, we need to fight for this. So packages should not be mandatory clause for empanelment. Packages should be based on scientifically worked template. This is our demand. And I think from ophthalmic, since Dr. Mathur is here, from AIOC side also we need to work for this. To demand, no packages and scientifically worked templates. So this will sustain us in the long run. And also there should be a third-party mechanism to take care of the grievances. If we stick to these 3 demands, so we can sail through this cashless, and it has to be equal stakeholders relationship, not somebody thrusting their rates on us, thrusting their MOU on us. So it has to be equal stakeholders. So if we understand this, we can also have a common redressal forum and stay behind with our association to face these complexities as well as challenges. Thank you so much.
Thank you, Nirmal. We'll have some discussion time later, perhaps.
Yeah.
We'll go on to Dr. Manoj Mathur to speak on the impact of NMC regulations.
Good afternoon. Good afternoon, everybody. Dr. Nirmal Frederick, I just want to give an update that tomorrow we'll be having a general body meeting, and at the managing committee level, we have decided to implead ourselves in the Supreme Court observation case, the PIL 680 that is filed in 2020 with the Supreme Court, where the Supreme Court gave a deadline of 1 month to the hospital, to the central government. In fact, they were directed a decade back to negotiate and finalize range of rates, not a not a package of rate. The Supreme Court had advised the government, central government, to be in discussion with the state governments and formulate a range of price line for the different types of procedures, but it was not followed and it was kept in abeyance. So the central government, the Supreme Court gave a directive to the central government that within a month's time, if you don't give us the range, we will give an interim direction to the central government to impose CGHS rates across the spectrum of healthcare industry, which is going to be a death knell for the private practice. It is going to be a death knell for the health industry. So that is the state of affairs. So since the Supreme Court has taken the example of cataract surgery range between 10,000 to 1,20,000, specifically AIOS in its wisdom, we felt we had subcommittee meetings and then we decided to implead ourselves to apprise the Supreme Court as to why this range of 10,000 to 1,20,000 for cataract surgery. That decision we have taken. Tomorrow we'll be presenting it to the general body and moving ahead with that. So one more important thing that arose last year was this NMC guideline. So this NMC guideline, what was the impact that we would have faced if those NMC guidelines were not kept in abeyance, and if they are implemented again? I have. Okay. Put my slide there. Okay. Yeah. So I shall be speaking about the impact of NMC regulations kept in abeyance as of now. If implemented again, what are the things that we are going to face, or what we can easily rectify and follow these guidelines. So the government of India, by this Gazette of India, notified this new NMC guidelines on the 2nd of August 2023, but this stated that National Commission Registered Medical Practitioner 2023 are hereby held in abeyance with immediate effect. This happened after hue and cry by the health industry. More so, this was kept into abeyance when the pharma industry met the health minister. So that was the impact. With that, we need to gauge as to what is our clout with the government. We are soft targets. The moment pharma industry intervened in this process, immediately the Gazette was kept in abeyance. So what are these changes? The NMC guidelines, they said, Indian Medical Council Professional Conduct Etiquette and Ethics Rules 2002, and how they are going to be changed if these rules come into effect again. The display of registration numbers. Every physician shall display the registration number accorded to him by the State Medical Council or the MCI in his clinic and in all his prescription certificates, money receipts given to the patients. Now this is sought to be changed, that the NMC will give a unique identified number all over the country assigned to him, her by the Ethics and Medical Registration Board. There will be one Ethics and Medical Registration Board, and this number, unique identification number, will be allotted to each practitioner, which is not an unwelcome move, I feel. Like instead of the State Medical Council number, the state councils giving you a certain number, at the national level, if we get a unique identification number, should not be a problem for us. Number two, the degrees that need to be displayed on your letterhead. Earlier we could use all these abbreviations. So now the RMP, with the new regulation, RMP shall display as suffix his, her name only the NMC recognized and accredited medical degrees or diplomas. The RMP shall not claim to be a clinical specialist unless he or she has NMC recognized training and qualification in that specific branch. So like if I have FACO, if I have MAMS, I have to convert my letterhead this way. Only the recognized degree under my name, followed by what all you want to write about yourself on your letterhead. The use of generic names of drug. So as of now, every patient should, as far as possible, this was the thing, as far as possible, prescribe drugs with generic names, and she shall ensure that there is a rational prescription and use of drug. Was changed to mandatory prescription of generic drug or non-proprietary pharmaceutical names only. Your prescription should have a generic and pharmacological name / you can suggest your brand. That is what we understood by this regulation, and especially so this was applicable to branded generic drugs, which are like, it is a non-proprietary drug but branded by the companies. So there was a distinction given between a patent drug, a generic drug, and a branded generic drug. Then this is what, like, every RMP should prescribe. The remedy is that the RMP should start using the electronic media. Here, if you want to write one name, you cannot write Brevex or you cannot write Simbrinza. You have to write brimonidine, the oblique brinzolamide combination, like that. So for that, how can you have to spend equal time as you spend to examine your patient to write your prescription. So the thing is, every RMP needs to shift to the electronic media with all these regulations. And the relevant record has to be fed, and with the name, qualification, and your unique ID. And you have to enter the generic name, the dosage, the period for which it should be taken, and then below it, you can write the brand name of the drug if required. Just imagine you are prescribing a multivitamin drug. What all you are going to write in your prescription? So, number 4, running an open shop or dispensing of drug and appliances by the physician. In the 2002 regulations, which are in vogue as of today, after the new NMC regulations were kept in abeyance, should not run an open shop for sale of medicine for dispensing prescription prescribed by the doctors other than himself or for the sake of medical and surgical procedures. What a doctor can have his own medical dispensation in his own clinic. We had an instant in our state. The face of the pharmacy should not be facing the roadside. That is, it should be facing your chamber. Your patient with your prescription can get your drug prescription dispensed from your pharmacy, but a patient outside was not expected to walk into your clinic and purchase the medication. That is what was implied. And here now, the new regulations also are something similar. RMP can sell medicines prescribed by RMPs other than himself for the sale of medical or surgical appliances. RMP is allowed to sell medication only to his or her own patients. And drugs prescribed by the RMP or bought from the pharmacy for the patient should explicitly state the generic name of the drug. So the emphasis on generic name is given. Now, in dealing with the pharmaceutical and allied health industries, the question of gifts, this is a main clause which is going to impact the medical profession. Now let me read this in detail. Gifts. A medical practitioner shall not receive any gift from any pharmaceutical or allied healthcare industry. Travel facilities. A medical practitioner shall not accept any travel facility inside the country or outside for vacation or for attending conferences, seminars, workshops, CME programs, etc. as a delegate. It is still existing. Are we following? Hospitality. A medical practitioner shall not accept individually any hospitality like hotel accommodation for self or family members. And cash or monetary grants. A medical practitioner shall not receive any cash or monetary grants from any pharmaceutical or allied healthcare industry for individual purpose in individual capacity. This is in vogue, but we know what is in vogue. Now, what is sought to be implemented with the new NMC regulation is RMPs and their families must not receive any gifts, travel facilities, hospitality, cash or monetary grants from pharmaceutical companies or their representatives, commercial healthcare establishments, medical device companies or corporate hospitals. This is so far so good. Also, RMPs should not be involved in any third-party educational activity like continuous CPDs, the CMEs, what we are used to calling. Professional development, this is continuous professional development, seminar, workshop, symposia, conference, etc., which involves direct or indirect sponsorships. A company can't hold its own CME on its own, which involves direct or indirect sponsorship from a pharmaceutical company or the allied health sector. We, as an organization, we sought a clarification on this as to what is our conference going to be, direct or indirect sponsorship. They are not supposed to sponsor your food. They are not supposed to even indirectly sponsor a CME. So what is it implies? It implies that the registered society, like AIOS is a registered society, this society is governed by Societies Regulation Act and not by the NMC. That way, a company can give sponsorship, can give a education grant, can give anything to a organization, but cannot indirectly sponsor or directly. It can't be a future XYZ company symposium, XYZ company CME, but the company can provide a grant or a aid to an organization like AIOS or like the State Ophthalmological Society. AIOS has the right to conduct a trade exhibition. For that, you are providing a space for the product demonstration. Something which I felt similar when there was a controversy about the life surgery recently. When you are providing legally a space for the company to demonstrate their equipment physically, what's wrong in that company giving a live demonstration of their instrument through a live surgery? That is a point to be debated. Like the records, the existing standards, they say physical documentation of all indoor patients for at least 3 years. The records need to be submitted within 72 years when needed by the patient or relevant authorities, and shall maintain a register of medical certificates issued. Whatever medical certificates you issue, this is the thing. And now, this has been changed to conversion of record in electronic media. Through the new NMC guidelines, the emphasis on electronic media is there. Efforts shall be made to computerize patients' medical records for quick retrieval and scrutiny. And within 3 years from the date of publication of these regulations, every practitioner has to convert to an electronic records. That is in store for us. Whenever these guidelines come into within 3 years, we all need to enhance our clinical setups with the electronic medical records. What is suggested for the medico-legal purposes, apart from record saving in your computer, see that every paper going out of your hospital to the patient should be scanned and saved in your computer to avoid any disputes. No doubt you are preserving the patient's data in your system, but what all documents you are giving a printout to the patient, it is always better to save that record in a separate folder for each patient to be to avoid future disputes. The consultation fee. The physician engaged in practice of medicine shall give priority to the interests of the patient. The personal financial interests of a physician should not conflict with the medical interests of the patients. A physician should announce his fees before rendering service and not after operation or treatment is underway. It is unethical to enter into a contract of no cure, no payment. These are the existing guidelines. What are the things that are supposed to be implemented if these new regulations come? RMP who attends on the patient will be fully accountable for his or her actions and entitled to appropriate fee. So this saving grace, the consultant is given the right to charge appropriate fee. RMP can refuse to treat or continue to treat a patient if the fee as indicated is not paid. This is another saving grace for the patient. But in case of abusive, unruly and violent patients or relatives, the RMP can document and report the behavior and refuse to treat the patient. This again, if it is implemented, is okay for us. Like it is a saving grace for us. With the patient, the right to consultation is not with the patient. The right to treat is with the physician. Rebates and commission, again, not much of a difference. An RMP shall not directly or indirectly participate in any act of division, transfer, assignment, subordination, rebating. There is a word change, but what is existing is sought to be continued with the new NMC guidelines. Advertisement norms. the medical practitioner as on now is permitted, howsoever permitted, to make a formal announcement in press regarding the following. On starting practice, you are entitled to an ad. On change and type of practice, on changing, Acha, Aarti has come. Okay, so I'll wind up another 2 slides. Okay, on temporary absence of duty, you can inform your patients, but all that is now given a certain sort of a leeway. You can advertise your practice to a certain extent in the new NMC guidelines. And last but not the least, that point number 10 is the social media or publicity. These are the guidelines. For the paucity of time, I would like to just say, I would like to read the last point. RMP should not post patients' photograph or scan images or CT or PET scan on the social media. A very important thing. Live surgeries, live transmissions on social media. Once an image is posted on the social media, it becomes data that is owned by the social media company and the general public, and it is no longer considered private. So endorsements, again, prohibition of endorsement. You are not supposed to give endorsement for products in the social media or advertisement. Thank you very much for your patient hearing.
Thank you, Dr. Manoj. And we have Dr. Aarti with us, who will cover 2 topics: handling medico-legal problems first, and then medico-legal aspects of teleophthalmology.
So, good evening, everyone. Am I audible?
Yeah.
So, you were supposed to hear this topic by Dr. Deshpande, sir, but unfortunately, I'll be speaking on this topic as sir has not been able to come for the conference. So, we can get in the medico-legal problem due to factors, few of which are in our control and few are not, like perception of the patient, unrealistic expectations of the patient, when the patient starts complaining and the outcomes with someone else, lack of compassion, and poor pre-op counseling. So, patient can send a legal notice through himself or through an advocate or a civil court, consumer court, MCI, state medical council, through police station, which is called as FIR, criminal court called as warrant, or other agencies such as health services and corporations. So, once you get the legal notice, basis of protection will be facts, circumstances, supportive documents, records, clinical references, and case laws. Facts that can be of help include facts that patient attended the OPD, got admitted and got operated. Points that are not accepted by the complainant but they are not supported by any document, and other facts that are supported by documents and the hospital records. So the court will also consider various circumstances like whether the patient has come to you of his own for planned primary treatment, or came as an emergency patient, or was referred from other hospital with complication or referred to a higher center for second opinion, or whether the patient has come of his own because of complication or unsatisfied treatment, or if the patient has reached in a very bad condition. So how to respond to a legal notice? You cannot refuse a notice, because even if you refuse it, it will be taken as granted that you have received it. The importance of the notice is to inform you that something has gone wrong somewhere and there are some allegations against you. So it's assumed that you know that there are some allegations against you. If a patient has sent, or an advocate has sent you a notice, it is not mandatory to answer. Other notices can be answered with the help of medico-legal consultant or advocate, as we know that doctors are not well versed with the law. Now, if in case you receive a legal notice, first and foremost important thing is to not panic. Just consider this as an opportunity to respond and resolve certain allegations which are not true. Don't try to communicate with the patient directly, as this may backfire you. If you get a notice through police, talk to your lawyer and discuss what can be done. So, highlighting the importance of indemnity insurance here, inform your insurer as soon as possible and get a written acknowledgement for the same. Try to collect all possible health records related to that patient, like case papers, certificates, consents, time to time what patient or relatives has given in writing, investigation reports, hospital records. This will make your case strong and put you at peace. Just remember one very important thing. Under Consumer Protection Act, the doctors or hospital is sued for negligence and not for the complication which are mentioned in the textbooks. Under Consumer Protection, civil liability for negligence is different in solo practice and corporate. Why is this so? Because of the Supreme Court's decision which says that whenever a patient lands himself in a hospital, private or government, his direct contract is with the hospital and not with the attending doctors or staff individually. Moreover, a patient does not know which of the doctor or staff will attend him. Therefore, the direct relationship is between the patient and the hospital. The Supreme Court says the patient, once they are admitted to such hospitals, it is responsibility to satisfy all the possible care was taken and no negligence was involved in attending the patient. In fact, it is the hospital who engages the treating doctor and therefore it is their responsibility. So the doctor is giving his services to the hospital and the hospital is giving services to the patient. So it's like a triangle. So in such cases, doctor is sued. He can be saved very easily. We all agree to this fact that prevention is better, cheaper and predictable than cure. So it is very important for us to know what is the ideal way to prevent all these troubles in medical practice. Consent is like double-edged sword. If it is taken properly, it can save you if needed, and if it is not taken properly, it can put you in trouble. Therefore, there can be various forms of consent. Best is to take written, informed, valid consent in patient's own language. Make sure the consent forms are kept properly and duly signed and can be produced whenever required. Record keeping. So records, if kept up to date, come for rescue to doctors under CPA. And if we look into the literature, we know how doctors have been in trouble due to improper documentation. Medical Council of India requires the doctor to preserve OPD papers for 3 years, indoors for 5 years, and in cases of legal complications for 30 years. Adult patients' record should be maintained for 3 years and children record for 21 years. Operation theatre is another place where things can go wrong. So make sure that every detail is noted in the patient record, like drugs used with the batch number and expiry date, IOL sticker, sterility indicator. Don't forget the anesthetist notes to be added whenever it is needed. So why do we need professional indemnity insurance? According to Consumer Protection Act 2019, District Commission has jurisdiction to entertain complaints where the value of the goods or services paid as consideration is up to 50 lakhs. For State Commission, it can be from 1 crore to 10 crore, and National Commission, it can be up to 10 crore. So if we study the important landmark judgments given in the past by the court, we will realize how important it is to secure ourselves. There are various indemnity insurance policies available, and your state societies can be of great help. Please note that complication is not negligence, but not knowing the complication has happened, not taking proper steps to rectify it, not referring or not taking help of proper specialist, leaving the patient on the unqualified or underqualified subordinate is negligence. So these are my take-home points. Informed consent, insurer, medico-legal consultant, lawyer and legal cell of the societies. Do not contact the patient directly. Prepare yourself. Keep all the documents in hand. Do not blame. Be well prepared. Be thorough. Study the laws, and if needed, take help of your seniors and AIOS legal team. Thank you so much.
Will you continue with your second talk?
Yes, sir. This is very interesting topic, medico-legal aspects related to teleophthalmology. So I would like to thank Anand Deshpande sir here for giving me this wonderful opportunity. If you see this image, you will realize the importance of telemedicine. So what happened in Ramayana? When Hanuman was sent to get Sanjeevani booty, he did not know which is the one. And since there was no telemedicine, Hanuman had to lift the whole mountain to save Lakshman. But is it possible in today's world? No. So WHO defines telemedicine as delivery of healthcare services where distance is the critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment and prevention of diseases and injury, research and evaluation, and the continuing education of healthcare workers with the aim of advancing the health of individuals and communities. So telemedicine has been in fashion since the year 2000 when the smartphones started making their presence in the market. Then came the messaging apps like WhatsApp and Telegram to popularize it. I'm sure each one of us would have given medical advice to n number of your friends and relatives over phone all these years. So is this what is telemedicine? However, the practice was banned by many state medical councils. Despite all this, the telemedicine still flourished. Let's get into a little bit of history of telemedicine a bit. There was a case in 2005 where a patient died due to acute pancreatitis that was being managed by a junior doctor as per the advice of senior doctor over phone. And the court awarded a huge compensation on the ground that patient was given medication without proper physical examination. Another psychiatric patient who was prescribed injection Serenase over phone died of cardiac arrest, and the compensation awarded was again very huge. Another case from Maharashtra that was observed was of a couple who were treating a pregnant lady over phone. The case went to the High Court and then to the Supreme Court, where the court stated that treating the patient over phone without physical examination amounts to gross negligence. So there are too many concerns when it comes to telemedicine. Who should be doing the telemedicine and for whom can it be done? What medicines can be prescribed? How to generate a prescription? What about the consent? How to maintain records? What if there are any complications? What is the liability of the doctor? And most important, how can an emergency situation be handled? COVID has set few things wrong, but few things were set in right direction. Board of Governors on 25th March 2020 superseded what was given in Professional Conduct, Etiquettes and Ethics Regulation 2002 and showed a different way to telemedicine, enabling registered medical practitioner to provide healthcare using telemedicine. It gives the same criminal and consumer liability to RMP as treatment given in person. So they categorize the drugs into various categories. This is the most important part of the presentation. It's important for us to have clarification on these categories of drugs. So first is category O. Paracetamol, ORS, multivitamin comes in this category. Also, medicine in case of any emergency, Government of India says everyone should take. For example, anti-malarials will fall in this category. Then there is list A medicine. So for these medicines to be prescribed in the first consult on telemedicine, you need to have a video consultation. It's important for us to know that ophthalmology eye drops such as ciprofloxacin falls in this category. So for us to prescribe these medicines, we need to have first video consent. This category also includes refill medicines, like if the patient is already on certain medicines, say anti-diabetics or anti-hypertensives. Then there is list B medicines, which are add-on medicines. Say patient is already on anti-diabetics and you want to add another medicine, then this falls in list B. So be very clear with list O, A and B. The prescription that has to be generated has to be exactly in this format, and it is clearly mentioned on this that this prescription is generated on teleconsult. So next question is, who can do telemedicine? So according to the notification, anybody who is enrolled with the State Medical Council under IMC Act 1956 can practice telemedicine. It was also specified that there will be an online course which one has to take, and the course will teach us about the details of telemedicine. The course is expected to be available in 2024 and we are keeping an eye when it comes. What are the fora that can be used for telemedicine? So one can use video, audio, text messages, etc. for telemedicine. For us, what is important to remember is ophthalmology drug falls in category A. So when we have to have video, we'll have to have video consult. So what cannot be done on telemedicine? First one, you cannot start a video call and tell someone how to do a phagosurgery. You cannot provide consultation outside the jurisdiction of India. So let's say you have a patient from USA. You have to advise the patient to go to the local doctor and get the treatment. Better to ask the patient that you can see your regular doctor. There are 4 types of telemedicine practices that can happen. Are patient to RMP, caregivers to RMP, RMP to RMP, and health workers to RMP. The guidelines to practice telemedicine are very well described in the manual which was generated by boards of governors in 2020, and they specified 7 elements to be considered before any telemedicine consultation. And this document is available online, so you can download it and read it. Identity of the patient is very important in telemedicine. RMP should know the patient and the patient should know the RMP. If the patient is a minor, teleconsultation is allowed only if the minor is consulting along with an adult whose identity needs to be ascertained. If the patient initiates the telemedicine consultation, then the consent is implied. But explicit consent is needed if a healthcare worker initiates a teleconsultation. Consent can be in the form of video or email, or you can send a consent form to the patient for signature and then patient sends back to you. All the consent forms are to be attached in the patient record, and to remind you, these records are to be kept as per the MMC guidelines for 3 years. Yes, as usual, it is on us when it comes to legal liability, so be very, very careful when you do the telemedicine. What is the definition of misconduct in telemedicine? RMP is insisting on telemedicine when the patient is willing to travel to a facility or request an in-person consultation. Misusing patients' images and data, prescribing medicines from the specified restricted list, and penalties for misconduct under telemedicine are as per the IMC Act. All the records for telemedicines are to be kept for 3 years. All the other rules and regulations of physical consult are applicable to telemedicine as well. Fees can be charged as you charge for your physical consult or whatever you feel is appropriate. You can generate receipt and or invoice for the same. So to summarize the legal aspect of telemedicine, doctor can choose the medium of teleconsultation. Doctor has to maintain same standard of care during teleconsultation as during in-person consultation. Patient is responsible for the accuracy of information. Caregiver is deemed to be authorized on behalf of minor or incapacitated patient. Doctor should maintain patient record for teleconsultation. Patient's personal data should not be disclosed or transferred without written consent of the patient. And doctor should not deny emergency teleconsultation but limit it for immediate assistance or first aid. Thank you so much.
Thank you. And thank you, Aarti, for helping us to finish the session on time. We have time for a couple of questions if anyone has anything to ask. Yes?